Good afternoon, everyone. I hope you're all keeping safe and well. My name is Michael Burns, and I'm President and CEO of the Princess Margaret Cancer Foundation. We are glad that so many of you were able to tune in today for our first webinar of the Future Forward series. In fact, we have had more than 300 people register to be with us today. It is also great to see the level of interest continue in the work that the Princess Margaret is undertaking, even during these difficult times. Even today, cancer is still the #1 cause of death in Canada and will be here long after COVID has passed. Today's session, Smart Cancer Care, Reimagining Patient Care During a Pandemic and Beyond, features two outstanding doctors who will tell us about the current state of care at the Princess Margaret during the pandemic, as well as some of the amazing advances that they have been able to achieve and some that are just down the road. Before I introduce our speakers, on behalf of the Princess Margaret, I'd like to begin by thanking you for your incredible support of the Princess Margaret Cancer Center. Thanks to you, the Princess Margaret has become one of the top 5 cancer research centers in the world. We continue to recruit leading scientists from around the globe who are breaking the boundaries of cancer research each and every day. And with your support and the incredible work of these leading scientists and clinicians, we continue to make great progress in our mission to conquer cancer in our lifetime. I would now like to introduce Dr. Monika Krzyzanowska, who is Medical Lead Quality, the Director of the Cancer Quality Lab, as well as the lead of the Princess Margaret COVID Steering Committee. Monika is a medical oncologist and a health services researcher at the Princess Margaret Cancer Center. The overarching goal of her research program is to improve the quality of care received by cancer patients. Monika obtained her medical degree and clinical training at the University of Toronto and completed a research fellowship at the Center for Outcomes and Policy Research at the Dana-Farber Cancer Institute in Boston. In addition to her clinical and research work, she holds leadership positions related to the quality of cancer care at the local, provincial, and international levels. Welcome, Monika. It is now my pleasure to also introduce Dr. Alejandro Berlin, who is a staff clinician-scientist and radiation oncologist at the Princess Margaret, as well as the clinical director of the Smart Cancer Care Program. He obtained his medical degree as valedictorian from the Pontifical Catholic University of Chile and underwent radiation oncology specialty training in Chile, Israel, and Canada. Dr. Berlin leads the clinical deployment of novel technologies such as AI-based radiotherapy planning methods for prostate cancer and the Smart Cancer Care Program. Welcome, Ali. Well, listen, it's great to have you both with us today. Perhaps I'd like to start by asking each of you how you and your families are doing during COVID-19. Monika?
Thanks, Michael. We're doing okay, but both my kids are homeschooling or schooling through the web and being over, and my husband is looking after them as he's also working from home. So we're managing. It's hard not to see our other loved ones, so more of our extended family and our friends, but you have to do what you have to do.
Absolutely.
Thanks for asking.
And Ali, how are you doing?
Yeah, thanks also for asking, and pleasure to be here. We're doing fine. Obviously, there's adjustment, homeschooling, 3 little guys jumping around in the house. So it has been interesting, new routines. So we have some fun routines to keep them busy and entertained, including family yoga, hopefully once a day. So I was totally new into it. So we had to reinvent some way to keep them busy, entertained, and to look back and be excited of some aspects of this kind of unique experience for all of us.
Terrific. Monika, maybe I can start with you. For the benefit of our audience here today, can you tell us what your responsibilities are at the Princess Margaret?
Sure. So, I mean, first and foremost, I'm actually an oncologist. So I take my responsibility as a medical oncologist and a clinician, it's always the closest to my heart. But I also have a number of roles related to quality, including as the medical lead for quality for Princess Margaret. And in that role, I chair the Princess Margaret Committee, Princess Margaret Quality Committee, and we're responsible for oversight for any quality and safety issues that may be taking place at the hospital. As some of you may know, several years ago, University Health Network, including Princess Margaret, made a strong commitment towards becoming a high reliability organization, meaning that we take safety very, very seriously. And so we review any kind of safety concerns, identify opportunities for quality improvement, and then work with frontline teams to make the improvements happen. So that's what I spend my other days doing if I'm not with patients.
Excellent. And Monika, let me ask you, you're also at Princess Margaret, the operational lead for the center's COVID-19 steering committee. And I know your plan was rolled out very quickly across not only our cancer center, but UHN. Can you talk about what it was like hitting the ground running and what measures you've put in place to facilitate safety for both our patients and frontline workers?
Yes. So it's been a very exciting 3 months, busy 3 months. We really did hit the ground running. I think the pandemic was declared, I think, March 11th, and we had our first steering committee meeting the same day. So we came together very, very quickly. And instead of being away for March break, I was here working with my colleagues to make sure that we respond quickly to what was happening. So there's been a number of things that we have implemented, from front door screening, so for our patients and staff to make sure that individuals who come in with symptoms are properly screened. We've introduced universal masking for both patients and for our staff. We have a clinic, COVID screening clinic, so any of our patients that may come in with symptoms would be taken to our clinic, and then they can be tested for the COVID virus because that may have implications for their treatment. We have introduced screening of asymptomatic patients, so any patients that will be going on treatment, they can undergo testing for COVID so that we can either have a discussion with them about treatment, and then if they need to come in, we take appropriate precautions. We've been really, one of the biggest changes, which Ali has been a huge, he's made it happen, is our virtual care, change to virtual care. We have moved, at one point, we're up to 80% of our visits, clinic visits, were switched to virtual care. So that's been a huge difference. That's allowed us to continue to engage with our patients, continue to provide care, but in a safe manner. On top of that, we've also had some wellness work for our frontline teams. Obviously, this is a very stressful time for our staff. So Dr. Mary Elliott, who's one of our staff psychiatrists, leads our wellness collaborative, and members from the psychosocial oncology team have been working with our teams across Princess Margaret to make sure that our staff are getting through this as best as possible. So really, I'm sure I've forgotten things because we've done so many different things over the last 3 months, but lots of thought has gone into this, and everyone can make suggestions, and we were always following up and trying to actually stay ahead of the recommendations, and sometimes really setting the standard for safety in this pandemic.
Outstanding work, and thank you to your colleagues for everything you've done, both for patients, families, and staff. Ali, let me turn to you. You're the clinical director of the Smart Cancer Care program. Can you describe for the audience what is Smart Cancer Care and what's your role within it?
Sure. So as you said, I'm the clinical director of the Smart Cancer Care program, that in a nutshell is an innovation incubator within and for the cancer center. And it's a new program that we started envisioning and planning last year, from mid last year approximately, and was officially launched at the beginning at the end of last year, 2019, and essentially responds to changes in the current landscape that are challenges for us. Is like we are facing increasing volumes because cancer is increasing the incidence, the treatments are getting better, and therefore the prevalence or the amount of people living with the disease is also increasing. There's also a shift in the healthcare world towards value-based and outcome-driven decisions and organizations. So there is a pressing need to quantify and improve practices. And also, I think the other element is a realignment towards patient centricity. Patients are getting more educated, more engaged. There's cost technology from other dimensions of life that has permeated into healthcare. So the Smart Cancer Care program is a research-driven program that we are aiming to create new models of care enabled by digital technology. And the goal is transform care by liberating patients and provider by a click, like removing the complexity of the cancer system while embedding discovery in day-to-day activities. So it's a comprehensive program, and we have fundamentally 3 pillars. One is increasing the organizational capacity to really create new efficiencies and improve the effectiveness of the way we deliver care. The second pillar is increasing research efficiency, because many times we do research on top of already demanding clinical practice. So we want to make research an integral component of providing care. So data is generated from the point of care and also feeding back into each individual encounter, so can enable research to be in the clinic and feeding back into the clinics. And the third component is improving patients and provider experience. So we want to improve the continuity of care, trying to avoid silos. That it's usually what happens when you do digital initiatives. And that's what we think, that those silos actually create gaps that increase or magnify potential pain points of our system. So increased capacity, increased research efficiency, and patient provider experience improvement is our 3 goals. And I think our uniqueness is that we give equal weight to those goals, because we don't want to do initiatives that one is at the expense of the other. So that's sort of the mantra of our team.
It's amazing. Now, what struck me in the early days of the pandemic was that Smart Cancer Care, which, as you mentioned, had been in planning for a number of months, and something that you obviously were taking the lead on, was that the pandemic actually accelerated our ability to deliver Smart Cancer Care in a matter of days as opposed to months. Can you give the audience a sense of how COVID-19 actually accelerated the rollout of the first phase of Smart Cancer Care and what that looked like?
Oh yeah, I have vivid memories of all the process. So we were working in a project for asynchronous messaging. So it's a new model of care that led us to map what an ambulatory clinic visit entails. So all the points that a visit's like, from booking, preparing the visit, patient arriving, holding the encounter, documentation, so on and so forth. So we had advanced mapping and understanding what that looks across the organization. And then the pandemic hit, and I remember vividly that was declared on March 11. Mary Gospodarowicz, our fearless director, knocked into my office one morning. I said, we need to shift 25% of our visits to virtual care. And that same afternoon, that 25 turned into 50%. And I was discussing with the team, and we're a team of 3-4 people. Sheena, one of the members of the team, who was actually deep on this mapping, she said, I think we can do it. This was March 12th. I said, I think, Sheena, you're crazy. I went home driving and said, maybe she's not crazy. Next morning, I said, probably she's not crazy and we should do it. And then we held a meeting, hands on deck, with several teams on March 13. And we said, we're going to develop and deploy a digital solution to actually close those gaps and facilitate the widespread adoption of virtual care across PMH. We did it in 13 days. So we launched on March 24th, 11 days actually. And the target of that 50% was reached within 4 days of launching. And as Monika said, there were days that we have reached actually 80% of our activities to be conducted virtually. On average is 65, 70%. And to date, we have supported over 25,000 virtual visits, and allowing what I think is the most meaningful result of all these is that we're back to our 1,000 daily visits. So we allow continuity of care to our patients. So I think that that's the main result that we achieved on this rapid transition.
Oh, that's amazing progress, and what a great story to share with today's audience. Ali, we've always at Princess Margaret respected and sought patient input. What has been the response from our patient population to virtual care, and what kind of feedback or ideas have patients been able to provide you and your team so that you've got some new things to think about as this expands and evolves at Princess Margaret?
Yeah, so that's a great question. At the end of each day, we actually conducted patient satisfaction and experience surveys. So we have received over 3,800 surveys to gather what's their appreciation of the virtual care. And some of the things that have emerged is the need for a more nimble platform for video consults. Most of our consults have been held by phone. So some people feel that they need the face-to-face interaction. So we're working, actually launching next Monday, a proof of concept with a new platform that we're partnering with UHN Digital, with the enterprise IT department. I think the other element is education. There's a lot of work to do in education here because many times patients feel that they're not prepared for their appointments. So improving how they could be prepared to that and tailor information instead of a generic toolkit that we give a bunch of information and then the patient has to navigate. Now that we have digitized part of that information, we can customize what type of information each patient will receive, when, how, and where. And that it's a great partnership that we're launching with the PM education program led by Mary Giuliani. The other element is patient-reported outcomes. There's a lot of work that we have done at the provincial level at a PM that when you came to your visit, you will complete some tailored questionnaires. And that's part of preparing to the visit too. And that also enables research and also enables steering a little bit of the discussion of how that encounter should be. So now we're thinking how we can do this remotely so we can empower patients to bring up elements that should be discussed in that encounter. And the other element that patients have seen and we have realized is the referral process. We want to reimagine the way our patients are referred to us and keep them more in the loop of that, because there's an element of black box for the patients that they're not totally aware sometimes where they stand, and that generates a lot of anxiety before they enter our system. So we want to embrace them a little bit better and improve there so they can feel more reassured in those uncertain times when they're dealing with fresh information from their diagnosis and there's new treatments ahead of them.
Excellent. Ali, we know that Princess Margaret is one of the most influential cancer research centers in the world, and our research doesn't just impact the close to 18,000 new cancer patients that come through our doors every year, but we are improving the lives and saving lives of people across the country and around the world. How do you see smart cancer care now extending its reach, perhaps beyond the GTA, and helping more patients elsewhere?
So again, I think that's a very important. We're here to improve, obviously, the care that we provide to our patients. But I think, as you point out, we feel that we have a moral innovation, or a moral obligation to think how things could be done different and expand our reach beyond walls. So, as I think I alluded that before, I think there's a good work to do in how patients can be seen by us and how can they be triaged to the appropriate experts within our centers or within our networks of collaboration. I think the other important piece that we have in our roadmap is rethinking when a patient is discharged and they're going back to work and their normal life, how can we remain part of the fabric of their care still when they're not under our direct day-to-day kind of supervision? So integrate better with the community care networks. And other big element, I think, is the capacity to deliver second opinions. That has been flagged as a need. I think There's many people who don't have access to PMH, and they have complex cases, and they're wonderfully managed across the province or beyond the province or beyond the borders of Canada. But they feel that they would like to know or feel reassured by opinions by our experts. And I think we should think, how can we integrate that to reach, as you said, beyond our physical constraints.
Excellent. You know, I'm interested to know what is the role of data science in all of this? Because from what I'm hearing, it sounds like you're both leaning heavily on mass data collection and analysis to inform your work. Monika, perhaps you can tell us a bit more about how data factors into the quality and safety work your team is undertaking.
So data is key. It's really essential. And I learned how to use data and how to manipulate big data during my fellowship 20 years ago in Boston, and I haven't stopped since. And I think even more today, data is even more important. So for example, in the sort of quality and safety world, the way that we're using data is to help us track trends. So for example, trends in serious safety events is a big area where we're doing some work. Actually, UHN as a whole is doing a lot of work in this area as part of our Caring Safely transformation. We're also using the data to understand the quality of care that we deliver that can help us identify areas where we could do better and areas for quality improvement. And then if we're doing quality improvement work, which there's several quality improvement projects, we need to know whether we're actually reaching our goals and how we're doing, whether the things that we're implementing are actually helping us achieve those goals. So we're using data on almost a daily basis. And Ali knows, because I'm always reaching out to him and asking him, more data and this data. And I think having the Smart Cancer team and all the tremendous work that they have been doing before the pandemic, but especially during the pandemic, has really allowed us to understand how we're doing. I can actually tell you that 80% of our visits are virtual because the Smart Cancer Care team has been able to track that and show us that. We've been able to track our patient volumes, the testing, our patient testing, and so we know how the data has been crucial to help us really deliver the care in the best possible way. And I'm hoping that in the future, now that we've built these systems and we've linked some of the data more, it will help us. My dream would be that we're using the data that we're collecting in real time, and it's helping us to just make decisions about what we should be doing tomorrow or next week, not looking back and seeing what's happened a few months ago or a few years ago. So more data.
Excellent. Thanks, Monika. Ali, obviously your team is also utilizing data science and AI to deploy novel solutions. Can you tell us a bit more about that?
Yeah, so I think Monika touched on that. I think there's this sentence that says data is the new oil, but useful only when refined. So it's not only about getting data and large amounts of data, or big data, how it's called, is also having proper interpretation and context for that data. And then if data is oil, then AI is that combustion engine that allows you to utilize the data. So as I said at the beginning, one of the pressing needs is being a value-based organization and an outcome-driven organization. So we need to collect those outcomes. We need to embed them in our clinical decisions. And I think Monika made the point perfectly. It has to be real time. Like, in order to really be dynamic, you need to be learning constantly. So that's what we're aiming on. The data science is becoming a learning health organization. And for that, we're building infrastructure and processes are always around data, but also around people and around projects. So we can really tailor this connectivity and start connecting these large amounts of data that we generate that sometimes seem to be in disjointed silos. And when you connect, then you can elevate that data to new levels of discovery. So we think that that's where the research around data we should be aiming to.
Excellent. Monika, now that it looks like we've started over the last number of weeks to flatten the curve, what are some of the key learnings around how we can better protect our cancer patients if there's a second, perhaps even third wave of COVID, or in the case of future pandemics that we can't yet predict?
Oh, that's $1 million question. So, I personally think that one of the most important investments from a kind of a big picture perspective is in public health. I don't think we appreciate how much our public health does to look out for us. They're kind of fly under the radar most of the time, but really they need to be watching what's happening. And I think actually with this pandemic early on, there were some surveillance systems that did see signal, but I don't think we were quite as responsive. So we need to kind of continue to invest in public health, continue to sort of watch what's happening so that if something were to happen, we identify it early and can implement things to control the situation. The second piece is actually that we need to learn from the current pandemic. One of the realizations that I had very early on is when we went to the literature to try to identify kind of what's worked in previous natural disasters or pandemics in terms of managing a system and managing patients, there was remarkably little in the literature on this particular topic. Toronto went through SARS almost 20 years ago, and you think there was a lot of information from that period of time, but there actually wasn't a ton of information to help. To help inform things. So I think we will need to take time to reflect what has worked and almost create a playbook of, if you have a threat such as this one, these are the things you need to deploy, and these are the things that have been effective. So to me, the sort of public health surveillance and the learning from the current pandemic would be key things as we go forward. And we have started actually doing that work. We're planning a study at Princess Margaret to really actually look at the impact of all the things we've implemented on outcomes in our patients.
Terrific. This is a question I have for both of you, and maybe we'll start with you, Ali. I'm really interested to know, what does the healthcare delivery and the patient experience look like 5 years from now?
Okay, that's a challenging one. So I would say before 5 years from now, I would expect a system that is more proactive and less reactive. And what I mean by this is that we want to have supporting systems that the patients can be more proactive in managing their symptoms, monitor their treatments, bring more professionals to coordinated care in anticipatory fashion, and not expect that there's complication or something like that to start bringing more people into the mixture, so we can escalate when it's needed. As I said before, having more tailored education that is prescribed. And then new things, like we're thinking on new things like how can we deliver certain treatments at home? So the perturbation on the patient and the people surrounding the patient that also get affected by the experience of cancer can be minimized. How can we have patient-centric reports? I think is another area of development. So patients now have access to the information. How can we give them access so it's in a way that they can understand and they can relate to that and can help them manage their disease more than exacerbate anxieties? So that's my ambition essentially for 5 years, is that we can kind of remove the system and allow people affected by cancer, and by that I mean patients and providers equally, to just focus more on the healing aspects of the disease. So the system itself is not adding a burden to the experience of cancer itself. After 5 years, I honestly have no idea, and I think that would be a lesson from this COVID pandemic. It would be a little bit pretentious to think that I can predict what's going to happen in 5 years. And whatever prediction I would make after 5 years, based on our experience today and the feeling that sky is the limit in innovation at PM, whatever prediction I could make, I just hope that I fail short miserably in the prediction. So I will just predict up to a 5-year horizon, as I did.
Excellent. Well, we appreciate your humility. Many people have been proven wrong when they've made predictions, but that's a great insight as to where you think healthcare delivery and patient experience will be in 5 years from now. Monika, where do you see the healthcare delivery and the patient experience being 5 years from now?
So actually, my thoughts are very similar to Ali's. I do think that one of the sort of pandemic positives has been that it's allowed us to introduce virtual care into routine care so much faster. There has been already some interest, but this really has accelerated it. And not just virtual care by physicians, but really virtual care by all of the team members. So our nurses, our pharmacists. So really, our survivorship program has been thriving. They've been doing physiotherapy with patients online. So I think it's really, and that will make it easier for patients in terms of accessibility. And the second piece, which I think the second piece was this issue of remote monitoring, which speaks to Ali's idea of sort of being more proactive. So rather than waiting for side effects to develop, like if we're watching our patients more closely, and with the digital advancements, it's much more feasible. We can prevent issues from sort of getting out of hand. And there's lots of data showing, like from pilot projects, that this actually improves patient outcomes. And I think the last piece, we've done a lot of, at Princess Margaret's, we've been very interested in personalized medicine, and that's been at the level of the tumor. So looking at different mutations and sort of matching treatments to those mutations. But I think we also need to look at a sort of a broader personalized approach as well, that we can always do better in terms of trying to figure out what are the needs of that patient and in their context and their caregivers in terms of through the cancer journey. And some patients may need more supports. Other patients might be much better at self-management. And so can we teach them to be better self-managers? So I think really much more expanding the sort of idea of personalized care beyond the tumor to really the whole patient and their sort of whole environment. And I think that really would be in 5 years, I think I agree with Ali. We that if we can be there at the end of 5 years, that would be great. And beyond that, we'll be open to new suggestions. And I think we've always been good at being early adopters or the innovators. So
Excellent.
that we'll have other options as well.
That's great. One of the things that, I've been at Princess Margaret now for 2.5 years. One of the things that I was immediately impressed with was obviously our global reach and the work that we were doing, but also the networks and the cooperation, both here in the GTA, across the country and around the world. And I think we all know that, a great collaboration and partnerships, networks make us stronger, better, and faster. Monika, maybe I'll ask you this question, and then Ali, I'd like to get your thoughts. Are there any more recent collaborations that you're especially proud of, and how you think it might lead to better cancer care in the future?
Sure, a great question. So obviously, I'm very proud of the work that the COVID steering committee has done. It's been there's 30 people on the committee, and you'd think a 30-person committee may be ineffective, but they've been the most effective group, or one of the most effective groups I've ever had the privilege to work with in terms of getting stuff done and quickly. But actually, the experience that I think really speaks to this for me that I've been involved with was actually in my role as the provincial quality lead at Cancer Care Ontario, which is a role that I held for about 7 years. And that particular collaboration is actually positively impacting thousands of patients currently in Ontario through the Care Path program, which is just the after-hours nursing teletriage line that's available to all cancer patients going through treatment. So probably about a decade ago now, our research team had used big data to look at patterns of emergency department visits and hospitalizations and cancer patients going through treatment. And we initially looked at women with breast cancer, and we were very surprised that a lot of the women were actually having emergency room visits or hospitalizations during treatment. So we had done a ton of work in our cancer centers around patient education and prescribing medications to prevent complications of treatment. But what was happening is that most of our patients were spending time at home in between visits to the cancer center. They were having symptoms, and then they were struggling with those symptoms, and sometimes they they ended up in the emergency department or even being hospitalized. And so I think we were a bit surprised by those findings, and the findings have been replicated in other types of cancers in Ontario. Cancer Care Ontario actually became interested in this work, and I had the privilege of being involved in sort of the work in working with 14 different regional cancer programs and their systemic treatment program committees to try to figure out some solutions for this. While we did some work to try to understand why this may be happening, what became clear is that we weren't doing a good enough job of proactive monitoring, this issue that Ali has brought up in his 5-year vision as well. And in fact, for some of the cancer patients, one of the complaints that they had was that, when I'm experiencing the symptoms, whether it be after hours or on the weekend, like I tried to call somebody and no one is available. If I just call Telehealth Ontario, they just tell me to go to the emergency department because they're not very familiar with cancer treatment or cancer symptoms. And so working with the 14 different teams from across the province, we sort of tasked them with thinking about, okay, what would make sense for your region to do? And one of the regions, actually where the South Lake Regional Cancer Center is at, one of the biggest gaps for their region was that they really had no one available after hours that the patients could call, or it was limited in their region. And so they set up a after hours phone line where oncology nurses with knowledge of cancer treatments were available to take patient calls. And in fact, that particular intervention was so successful that it sort of spread like wildfire through the province. Other centers signed up, and eventually Cancer Care Ontario actually decided to support it provincially for patients. And it's currently in existence. It's been in existence for about 1.5 years. And all of our patients have access to the line, and I've heard from many patients how beneficial this is. So I think that was a really great example of what, data, quality improvement, collaboration, and working, the kind of frontline grassroots innovation together with working with a decision maker can do for our patients. So I think that would be one of my kind of proudest collaborations of recent.
Excellent. No, it's a great overview. And Ali, how about you?
Well, I want to make I'm a definitions guy. So you use two concepts of cooperation and collaboration that commonly are used indistinctively, but cooperation is usually when people share resources or information to support each other's goals, versus collaboration when it's actually working together towards a common goal. So I think the best example of a collaboration was what we did with the virtual care management system, that solution that we developed on the virtualization of care, because we had a set ambitious goal that was clear for everyone, like more than 50% should be kept outside of the PM walls, but we should aim for continuity of care. And something happened that the stars aligned. So we had tremendous support and guidance and trust from leadership. So it would be inappropriate who was the and continue.
Oh, Ali,
spearhead. Okay. Like I could be named, but the Smart Cancer team with Mike, Sheena, Alex, Hannah, Adam, superb collaborations from the Tegna Institute within UHN, Tran, Luke, Justin, Julia, and like I can say the names because now it's people we were working with them in and out all the time, crazy hours, crazy times, but it was just a joyful experience because we had this sense of commitment. So I think that is an example of collaboration and sets a tone for us moving forward. Like we have now started new initiatives, a nurse-led clinic for COVID and other, and that's going to spearhead other things that we have in our roadmap. So it's a contagious experience. I think when collaborations happen, you like the collaboration, I enjoy it, but I'm not satisfied with the VCMS because you can feel what you can do when true collaboration happens.
Yeah, no, that's outstanding. It's good to see too that even despite the pandemic, things are accelerating and great partnerships are being formed that are going to last and have a huge impact on patients and our delivery of care at Princess Margaret. I know that we do have a number of people who have submitted or posted questions. So I do want to ask you both one last question before we turn to the audience for their questions. And that is, Monika, I'll start with you. What are you doing right now to stay healthy and manage, obviously, a very stressful period during this pandemic? Maybe shed some light as to what has perhaps changed in your routine during the day.
So I was an intermittent runner, but since the pandemic, I've started running regularly and started running in the mornings before the 8 a.m. meetings, which is and doing a lot more yoga. So I've been trying to keep physically fit because lots of sitting around and sort of Microsoft Teams and Zoom meetings. So trying to keep fit.
Oh, that's great. And Ali, how about you? What have you been doing to relieve stress during the pandemic?
So I think similar. I've tried to keep my mind, my body, and my soul busy. So mine has been work, actually. The focusing on work has been refreshing during this experience because of the innovation that we're doing. My body, I've been also exercising more than I used to, and I also started building a fence on my backyard that I had it there sitting for a while, that project, and reading a lot of other topics. Many of my esteemed colleagues and friends have shared books, and so now I'm devouring books more than ever. And the other thing I've done is try to isolate myself a little bit from media. I'm not up to speed in all the news. I try to touch Twitter, that I'm there. Sorry, no one is perfect, but I touch there just to put a funny comment or something like that. But I try to honestly try to get isolated a little bit of the craziness of the stuff, so I can focus on actually all the blessings that we have despite these challenging times. Like, we can impact care of patients, we can be more with our families. So there's a lot of good stuff happening around these, and sometimes media steers your attention to spots that don't contribute on a positive note.
Yeah, no, I think that's good advice for all of us. Well, listen, I want to thank you both for your candor, and now we'll turn to those questions from the audience that were submitted in advance, and we want to thank those that did that, as well as those apparently that have come up during our conversation. And let's turn our attention to that. So I'll lead here and ask the first one, which is, how do you rate the effectiveness of virtual care over face-to-face care? And do you expect the balance between the two to shift towards more virtual care post-COVID necessity? Ali, do you want to take that first one?
Sure. So it will depend a little bit what you mean by effectiveness here, but I would say the amount of virtual care we provided in February 2019 was, in any given day, was between 0 and 1.8% of our visits. And now we're at 70% roughly. So we, as I said, have conducted surveys to providers and to patients daily. So we have 3,800 surveys to patients to see what's their experience with care, what they feel that has been compromised on the care. And the vast majority of patients are extremely satisfied with their virtual care. They don't feel the quality of care is compromised compared to the in-person visit. Interestingly enough, from a provider perspective, the percentage that feels that there's a compromise is slightly higher. So it's not unusual to see this mismatch between providers and patients, so it wouldn't be the first time. So I think what's the right percentage? I don't know. I certainly think, and I'm convinced, that this is going to remain in the fabric of care. The question is how to incorporate it to the care paradigm. When a patient can be seen by virtual care, when has to be escalated. And remember, like, if you see a patient virtually and something arises on that encounter, you can always bring that patient to the clinic. So there are fallbacks, positions. Perfection is enemy of the good on the perfect percentage division here. But the answer would be, I think, would be massively more than we were doing before. And that also generates an obligation for us to really understand where virtual care is appropriate for which patient, in which part of their journey, in which part of their treatment, so on and so forth.
Excellent. Well, listen, there's a lot of really good questions here, and perhaps, Monika, you want to tackle this next one. And I think it's a great one, which is, how do we include the patient's individual preferences when deciding how virtual care is delivered? Instead of a phone call, I might want video. Maybe sometimes I want to come in. Right now, the doctor gets to choose. Do I get a choice?
Great question. So I think everyone should have a choice. And in my practice, I give all my patients a choice. The way that I've sort of approached this, and I think many of my colleagues as well have, is that, we would look at the patient's appointments that are coming up and try to figure out, is this a visit that would make sense to be conducted virtually? During the early days of the pandemic, we certainly really wanted to have more visits because we were worried about the safety for our patients in terms of coming in and exposure. And ideally, actually, most of the visits would be happening through video. The challenge, which Ali has alluded to earlier on today already, has been that the provincial platform for virtual visits is quite cumbersome, and there can be connectivity issues, and it takes a bit of time to set up, especially on both the provider side and the patient side. I had happened to be using that platform prior to the pandemic, so it was already set up, and I've encouraged many of my patients, when we're making the changes, I've been asking, offer them the video appointment if they're willing to set it up and join. But I have to be honest, most patients have chosen the phone because it's very overwhelming to try to, set this up, especially if they're not feeling well or, overwhelmed with everything that's going on in the world. So I think patients should have the choice. And then, if patients, just like Ali said, if you're speaking with a patient and you feel that coming in makes sense because you need to do a physical examination, or perhaps they need to do a blood test. So we're trying to coordinate and batch visits. But I think going forward, in terms of patient preference, absolutely should be there. Video if we can. So I'm looking forward to this new platform that the team is going to be launching. This will be here to stay. We just need to make sure we figure out which visits are the appropriate visits, and then give our patients the choice.
Great. And Ali, I'm going to assume that you agree with what Monika said, that patients deserve that choice. So I'll give you a chance. Is there anything you want to add to that, or I'll go to the next question?
No, I totally agree.
Yeah. Okay. So Ali, maybe you can answer this next one, or at least start, which is, will Ontario's health data platform be leveraged? And if so, how do you see data collection being integrated with routine care?
That's an informed question. So, well, the Ontario Health Data Platform provides anonymized data. So that's the main thing. So it doesn't provide necessarily data that you can use for that individual patient. But so I would say that is really relevant for discovery at the population level and seeing trends at the population level. I do like the second component is like how we see data collection being integrated into routine care. And that comes to the second pillar that I mentioned, that it's research efficiency. So we are building tools here not to improve our operations, but that's a byproduct of our efforts, and it's a valuable byproduct, but it's actually to allow the seamless collection of data and outcomes and results of our care as integral part of our activity. So the way of we seeing these digital solutions being integrated into the care is that even without noticing, sometimes you will be collecting data elements that are informing the results of our care. So we need to be very strategic and smart to incorporate those elements in order that it allows better provider and patient experience, but at the same time allows us to collect that data robustly and routinely on all our encounters, so we can really learn of our day-to-day activities. So what we're thinking here is that sometimes we have clinical research protocols that they're very strict and they collect a huge amount of very granular and depth of data. We want to reach the day-to-day clinical data to the same level of quality and curation. So then it's not a matter anymore of having the data available, is a matter of having the right questions. So you can actually poke the data and try to find answers to your problems into day-to-day without that chasm or vacuum that sometimes you have between the question, the gathering of the data, and then figuring out an answer that sometimes you have to inter or extrapolate because you don't have all the data elements to answer that precise question that you had.
Excellent. Monika, is there anything you'd like to add to that?
No, I mean, I think we really, it's important for us to continue to collect data, but to use that data. I think it's the using of data. We have lots of data. The province has had lots of data, but I don't think we're using it optimally. I mean, obviously it has to be curated, like Ali had mentioned before, but I'm hoping that in the future we'll be using data much more real time and much more routinely.
Excellent. Ali, let me go back to you for a moment. And Monika, I'd like to get your perspective as well. What have you found to be the biggest challenges for your respective teams in transitioning to virtual care within the Cancer Center?
I mean, for me, I think and I think this speaks to all the other teams as well, has been, we work as a team. And so when you do when a patient comes into the clinic, they at the front desk, they meet our PFCs, so our front desk staff. And many of our front desk staff know our patients. They come into the clinic room, they spend time with our nurses. Our pharmacists are sometimes around and they'll come in and speak to the patients. We have trainees who've been involved. And so normally when one of our patients comes in person, they're interacting with several different members of the team. With virtual care, it has been a more one-on-one experience. So that transition took a bit of time but with the help actually of the Smart Cancer Care team, we are now, and with our nursing and pharmacy colleagues, we've now figured out models of care where the nurses and the pharmacists can call patients at a different time. So they're still getting that multidisciplinary care, maybe not at exactly the same time, but sort of in a longitudinal fashion. So we're figuring out how to address that, but that kind of team-based care at the one visit has been the one thing that has been a challenge for us. And the administrative burden, right, with having to switch all the calls and all that, but that's a small burden.
Yeah, excellent. And Ali, how about for your teams or even your observations as you deployed Smart Cancer Care across the center?
So I can take probably more than my personal experience because I was a heavy user of virtual care before. So I haven't felt all the pains of the transition myself directly in my clinics, but I felt it as directing this program. So I think one of the pains is that perfection is enemy of the good. Like we did a huge transition rapidly and we had to make decisions to say, well, we start with one-on-one and we grow from there. So there's this tension between managing expectations and fostering people to have high ambition. So there is you need to find that right balance. I would say the other element that it's challenging for these in the time of crisis and the migration that I don't know if it's a challenge, but here I'm going to quote Mary that she says, for us, failure is not an option. So having that pressure in the transition while doing the two previous steps, I think is important and was part of a challenge. And the last thing I would say is that there were so many moving pieces, both at the individual level, professional level, personal level, system level, cancer center, you name it. So I think the most challenging thing to keep focus for people sometimes is something that Mike Lovas from my team has always remind us. He's a cancer survivor and he's a proud member and key member of our team. And he says, a quote from someone else that says, the most important thing is to keep the most important thing, the most important thing. So having that focus on saying, well, doing this for our patients and sometimes leaving aside the convenience of saying, well, my clinic used to be run like this and I used to like my old ways of working and doing that system change has been a challenge. I think we have circumvented the challenge to some extent, better in certain areas, worse in certain areas. but is obviously change is challenging, and COVID is a challenging time, and it's not convenient, and we had to just use this as an opportunity to change the ways we work. So virtual care is just one example, but I think it replicates in different areas the same issue across the board. So it's a bit of overwhelming feeling at some times.
That's excellent. We're actually almost at the top of the hour, and I want to be respectful of both your time and our audience time. So why don't we end with a prediction or a question that you're going to have to predict. And the question was, when we get back to our new normal, what is your prediction with respect to the number of people that will be using virtual care and not necessarily coming into the cancer center going forward? Do you anticipate that there will be significant numbers of people using that channel versus traditionally coming in for their consultations? Let's start with Monika.
So my prediction, I'd probably say 1 in 3 visits virtually. It might be a bit on the conservative side, but I think 1 in 3 is my prediction.
Excellent. And Ali, what about you?
I said I don't like to do predictions, so it's a challenging one because it depends on the context. Again, like across the board, it's very different diseases, different stages, different patients. And also there's a factor of dependency here of the healthcare system understanding the value of these moving forward and having proper structures to reimburse for these services in a way that incentivizes providers and patients to actually tap on these useful resources. So I would like to see a 50-50, and I think is an ambitious goal. But by virtual care, I'm not only thinking about video or phone, I'm also thinking about messaging, asynchronous messaging, and other models of care. So I think there's an armamentarium of virtual care resources that it's only going to expand it, and I think it should be a 50-50 type of a balance.
Oh, that's terrific. Well, listen, we've recorded both your predictions, so we'll come back in a few years and see how right or wrong you might have been. Listen, folks. First of all, let me just say that we want to thank everyone who submitted or posted questions for this session, and obviously a big thank you to Ali and Monika for telling us all about the work that they're involved in and the passion that derives them every day. We're so fortunate to be able to attract this kind of level of talent at the Cancer Center. And I think we can confidently say that we all feel more informed and safer knowing people like you are tracking and tackling the big questions around quality and safety. And we're working every day to improve cancer care delivery for patients at the Princess Margaret and beyond. Our next session of this series will dive even deeper into how the Princess Margaret is using data science and AI to advance our need for more responsive patient care. The session will feature 2 outstanding researchers, Dr. Benjamin Habib Kans, Senior Scientist and Scientific Lead, Data Science Program, and Dr. Thomas Purdy, Medical Physicist at the Princess Margaret Cancer Center. I hope all of you will be able to join us again. You can register for that session, as well as all of our sessions spotlighting research and supportive care on our website at thepmcf.ca/webinars. I hope all of you enjoyed today's session as much as I did, and we look forward to seeing you at the next one on June 24th. Until then, stay safe, be well, and take care of one another. Thank you so much.
Thanks.
Thanks.
Thanks, everyone. Bye.
Bye.